Welcome to the debate. Diabetic peripheral neuropathy is, well, it's one of the most persistent and challenging chronic complications of diabetes. And for specialist practitioners, the frustration is really quite acute. We lack truly targeted primary treatments, and frankly, the traditional medical approaches often yield clinically suboptimal results. This necessity is, I think, what drives researchers to explore adjunctive therapies, things outside of the standard pharmacological toolkit. So today, we're focusing on a recent systematic review and meta-analysis published in Medicine. It rigorously evaluated the clinical efficacy and safety of adjunctive hyperbaric oxygen therapy for patients struggling with diabetic peripheral neuropathy.
Right. And the essential question, particularly for our specialized audience, is whether the current meta-analytic evidence, which, yes, it reports certain statistically significant clinical improvements, actually has sufficient methodological integrity. Can it reliably establish hyperbaric oxygen therapy as a safe and effective adjunctive treatment? We really have to weigh the promising statistics against the extensive methodological limitations and inherent biases that were explicitly identified in the underlying studies themselves.
Well, my position is clear. The collective numerical power of the pooled data, which encompasses a substantial number of patients, presents, I believe, strong evidence of significant efficacy and a favorable safety profile. Given the substantial clinical need for a better solution in diabetic peripheral neuropathy, these findings really compel specialist physicians to seriously consider this therapy as an addition to standard care.
And I'll be arguing that the review's acknowledged methodological deficiencies, along with the severe publication and performance biases within the included trials, make this conclusion of safety and effectiveness rather weak. For specialists who prioritize high-certainty evidence, these findings, well, they need to be approached with extreme skepticism. They might serve as a basis for hypothesis generation, sure, but certainly not clinical instruction at this stage.
Reported effect. This systematic review is built upon 14 randomized controlled trials, pooling data from over 1,300 patients. The analysis concluded that hyperbaric oxygen therapy significantly improves clinical outcomes compared to standard therapy alone. Now, first, let's consider the overall effective treatment rate. That's a critical clinical benchmark. The pooled analysis showed a significantly higher effective rate for the hyperbaric oxygen therapy group compared to the standard therapy group. It reported a, remarkable odds ratio of 8.06. That figure indicates that patients receiving the adjunctive therapy were 8 times more likely to experience a defined clinical improvement. And the statistical significance for this finding was overwhelming, p less than 0.00001. Crucially, this benefit seems to extend far beyond just subjective reporting. The improvement was objectively demonstrated across the gold standard for electrophysiological assessment, nerve conduction velocity. The hyperbaric oxygen therapy group showed significant improvements in both motor nerve conduction velocity and sensory nerve conduction velocity across all major nerves tested: the median, ulnar, peroneal, and tibial nerve. For instance, the mean difference in motor nerve conduction velocity for the median nerve was 5.53 meters per second. Now, this magnitude of change isn't trivial. It really suggests genuine biological repair, or perhaps functional enhancement of the large nerve fibers. And regarding safety, only 6 minor adverse events, things like earache, tinnitus, and vertigo, were reported across the 201 patients in the hyperbaric oxygen therapy groups that actually provided this information. This indicates a profile comparable to the standard therapy group, statistically speaking.
Okay, while that odds ratio of 8.06 is certainly a headline figure, something that might catch the eye, I remain highly unconvinced because those, let's say, attractive numerical results are built on what I see as a structurally unsound foundation. We really have to prioritize methodological integrity over just the statistical magnitude. The core problem, as I see it, is the quality of the primary research itself. Think about this. Out of all 14 included randomized controlled trials, not a single one reported using double blinding. Now, we're dealing with diabetic neuropathy, where patients are often keenly aware of their symptoms and their therapy status, especially if they're undergoing hyperbaric exposure, which is a pretty unmistakable intervention. This complete absence of blinding introduces profound performance bias, and that's particularly devastating for a composite measure like the overall effective rate, which, let's be honest, often relies heavily on subjective patient reporting of symptom changes or maybe a researcher's interpretation of non-electrophysiological endpoints. If the researchers or the patients know the treatment group, bias is, well, it's practically inevitable. Furthermore, selection bias is likely rampant. Only 2 studies explicitly mentioned using proper randomization methods like random number generation. That leaves the integrity of the patient allocation deeply suspect in the other 12.
I appreciate the focus on methodological rigor, and look, no one disputes that double blinding is the gold standard, particularly in trials looking at subjective things like pain. However, let's consider the mechanism of action for hyperbaric oxygen therapy. It increases dissolved oxygen levels to enhance nerve tissue oxygen supply, reduce hypoxia, and potentially promote growth factors. This provides a solid theoretical foundation for the observed results. And more importantly, we are not just debating subjective symptom relief here. We are observing a robust, statistically significant change in objective electrophysiological markers. Improvements in nerve conduction velocity are hard, measurable outcomes. They suggest genuine biological recovery of large nerve fibers, and they align perfectly with the theory that improved oxygenation could mitigate the microcirculatory damage that's characteristic of diabetic neuropathy. So, given that the objective data supports the theoretical mechanism, shouldn't we afford the pooled results a higher degree of trust, especially since they are consistent across 14 separate trials? That magnitude of improvement, 5.53 meters per second in the median motor nerve conduction velocity, that has genuine clinical relevance when we think about predicting long-term neuropathy progression.
That's a compelling argument about the objective markers. I grant you that. But it raises the fundamental question: are we actually pooling reliable measurements? I remain highly skeptical precisely because of the overwhelming heterogeneity documented across these very objective outcomes you mentioned. When we look at the statistics for pooling these studies, the I-squared value, the measure of heterogeneity, for the effective rate was 56%. Okay, maybe borderline high, but more alarmingly, the nerve conduction velocity analyses, the very ones you cite as objective proof, frequently showed I-squared values well above 70%, even reaching 90% for some specific nerve measures. Now, for specialists interpreting meta-analyses, an I-squared value of 70% or more means the individual studies are measuring substantially different underlying effects. Or perhaps worse, they might be employing wildly varied assessment protocols, different treatment pressures, or session durations for the hyperbaric therapy itself. Pooling such heterogeneous results is, it's like averaging apples and oranges. The final pooled mean difference starts to lose its clinical interpretability and, frankly, its trustworthiness. So the consistent finding of high heterogeneity, coupled with the systemic lack of blinding we already discussed, means we are effectively aggregating poor evidence. And that doesn't magically become high-certainty evidence just because the pooled mean difference looks large on paper.
It highlights variations, perhaps in treatment delivery protocols, across the included studies. But let's look at the practical implications here. The consistency in the direction of the effect across all 14 trials, despite this variability in methodology, doesn't that suggest there's a core biological phenomenon at play? Some benefit from increased oxygen delivery to ischemic nerve tissue? It seems far more plausible, to me at least, that this consistency reflects a genuine physiological effect than it is that 14 independent, unblinded research teams, all operating in different clinics, somehow generated the exact same type of measurement error, all leading to this substantial positive mean difference in nerve function. The heterogeneity might indicate protocol variability. Yes, absolutely. But the uniform positive findings, I think, suggest the intervention still works across that spectrum of variability.
Respectfully, I believe that assumption of a uniform positive finding is precisely where the evidence is weakest,
And this brings us squarely back to the serious issues of publication bias and generalizability. We simply cannot overlook the fact that the quantitative assessment using the Egger test indicated the presence of significant publication bias, with a p-value less than 0.05 for 3 really crucial indicators: the overall effective rate and the sensory nerve conduction velocity of both the median and peroneal nerves. This asymmetry in the funnel plot isn't just some benign statistical artifact. It strongly suggests a systemic failure. It implies that studies showing lower or perhaps even null efficacy for these key outcomes are systematically missing from the pooled data. They just weren't published or weren't found.
If the positive results we do see are inflated because negative data is missing, then the clinical relevance of that impressive-sounding odds ratio of 8.06 is severely compromised. Wouldn't you agree? And compounding this issue is the fact that all 14 included studies were conducted exclusively in China. This strong regional constraint severely limits the generalization, the extrapolation of these results to other populations or other clinical settings. Diagnostic standards might differ, patient comorbidities could be different, baseline neuropathy severity might vary drastically elsewhere. So this is at best a locally confined evidence, not globally actionable guidance for specialist care.
I see why you emphasize the regional and publication bias constraints. There are undoubtedly genuine limitations. However, let's look at the systematic review's methodology itself. It was comprehensive. They searched 8 major international and Chinese databases. So while the regional bias is acknowledged, the researchers did make an extensive effort to locate all relevant data. Furthermore, while the funnel plot was indeed asymmetrical for sensory nerve velocity, the Egger test result was actually non-significant for the motor nerve conduction velocity outcomes. And arguably, motor nerve conduction velocity represents a more robust measure of nerve health, less susceptible perhaps to subjective influence. We need to distinguish between physiological effects and potentially biased psychological reporting. The consistent improvement in motor nerve function, a parameter that's arguably more difficult to influence purely by bias, still lends substantial credence, I believe, to the potential biological effectiveness of this therapy. These foundational physiological effects, things like improved microcirculation and maybe influence on neurotrophic factors, these are universal mechanisms of action. They seem less likely to be purely artifacts of a specific regional research culture or some kind of reporting bias.
Okay, let's shift the focus slightly then to patient safety, because for any new adjunctive therapy, particularly one involving, a physical intervention like pressurization, we absolutely must have robust safety data before even considering adoption. The review's conclusion that there was no significant difference in adverse events compared to standard therapy is, I would argue, highly unreliable. And once again, the lack of blinding is the primary culprit here. Since no study was blinded, patients obviously knew they were receiving a pressurized treatment. This creates a substantial risk of suppressing the reporting of minor but common side effects related to pressure changes, things like earache, transient tinnitus, or maybe some vertigo. Patients might just tolerate it, thinking it's part of the treatment. But maybe more critically, the adverse event data was only reported by 4 out of the 14 included studies, just 4. That means the entire safety conclusion is derived from very limited data reported by only 201 hyperbaric oxygen therapy patients in total across those few studies. Now, for specialist practitioners, basing a safety assessment on such sparse and potentially biased reporting, especially for a physical intervention with known potential side effects, well, it's unacceptable. The evidence base here provides a clear information gap, not really a reassuring safety profile.
The reporting gaps, though I might frame it slightly differently. Yes, only 4 studies detailed the events thoroughly, but the critical finding, I think, remains that the therapy is not associated with catastrophic or irreversible side effects. And that's a major concern when we're starting potentially aggressive pharmacological treatments for diabetic peripheral neuropathy, isn't it? The reported side effects were minor and transient, 6 events out of 201 patients who reported data. That's still a low incidence, objectively speaking. So given that diabetic neuropathy is a progressive and often debilitating condition, and one for which we have frustratingly few truly effective options, the low, contained risk profile, even if it is incompletely reported, suggests hyperbaric oxygen therapy is a relatively safe option to pursue as an adjunct. Let's not forget The authors of the review themselves deem the overall research quality acceptable, despite acknowledging the limitations. When standard care is clearly failing for a patient and a therapy presents a clear biological rationale, has objective proof of efficacy like the nerve conduction velocity data, and shows minimal reported harm, maybe that threshold for acceptance necessarily lowers just slightly, perhaps justifying its use while we await that perfectly designed, multi-center, double-blinded trial that we both agreed is needed.
But that argument, the argument for lowering the threshold of evidence due to clinical desperation, that's a dangerous path, particularly for specialist adoption. We really must hold the line on evidence standards. If the primary clinical outcome, this effective rate, is potentially compromised by publication bias, and the entire evidence base is geographically constrained and built entirely on unblinded studies, well, then the positive results should simply function as a strong hypothesis. It absolutely demonstrates the potential of hyperbaric oxygen therapy, I'll grant that, but not its established utility. We must demand external validation through high-quality, randomized controlled trials conducted in diverse global settings that adhere rigorously to blinding standards. Without that, we risk introducing a widely adopted treatment that offers potentially inflated perceived benefits based on what is essentially localized, methodologically weak research.
While the need for global high-quality trials is undeniable, and I agree with that completely, we also mustn't ignore the cumulative weight of the evidence we currently possess. That consistency in the improvement of motor nerve conduction velocity across all 14 trials, that still suggests, quite strongly I think, that the therapy is genuinely achieving some level of physiological reversal or at least slowing of the neuropathy. This objective finding, which aligns so well with the known pathophysiology of oxygen deprivation in diabetic peripheral neuropathy, provides enough evidence, in my view, to support its judicious use. As an adjunctive, non-invasive option, particularly in those patients who are unresponsive to conventional care. We are not advocating for a complete paradigm shift here, but rather for considering its inclusion in the therapeutic toolkit when our existing options are so limited. So, to summarize my position, the meta-analysis offers strong numerical evidence of efficacy. It specifically demonstrates that adjunctive hyperbaric oxygen therapy significantly enhances both the effective treatment rate by quite a dramatic margin, that odds ratio of 8. And perhaps more importantly, objective measures of nerve conduction velocity. Yes, acknowledging the need for further, higher quality validation, the consistent positive results across numerous trials still support, I believe, the therapy's immediate role in addressing the challenging pathology of diabetic peripheral neuropathy as a potentially safe and effective adjunctive measure.
And from my perspective, the weight of the substantial methodological limitations, particularly the complete absence of blinding in all included trials, the high statistical heterogeneity across key outcomes, and the documented publication bias affecting primary indicators, this must severely temper any enthusiasm for clinical adoption among specialist physicians. The evidence base, as it stands today, provides a compelling hypothesis, certainly worthy of further rigorous investigation, but it does not provide robust scientific guidance. Definitive clinical conclusions require that validation through high-quality, rigorously designed randomized controlled trials conducted outside of the current regional constraints. That's what's needed to provide the level of certainty required for routine, evidence-based practice.
I think this debate really illuminates the critical distinctions specialist practitioners constantly face. The difference between statistical significance derived from pooled data and the true clinical reliability of that data, especially when the quality of the contributing studies is, shall we say, compromised.
Exactly. And that distinction serves as a crucial reminder that evidence, particularly when it presents novel or perhaps controversial therapies for persistent and difficult conditions like diabetic peripheral neuropathy, must be rigorously challenged and thoroughly vetted before it can genuinely sharpen our clinical understanding and actually change patient treatment protocols.